Hello and welcome to the Endocrine Society's 100 Years of Insulin, Breaking Down Barriers to Diabetes Care webinar. Today's discussion is made possible by our partner, Lilly. My name is Colleen Williams, and I'm the Manager of Public Relations here at the Endocrine Society. We'd like to go over a couple of reminders before we get started today. You can type your questions into the question box on the right-hand side of your screen at any point during the webcast, and they will be addressed at the end during the Q&A. Please be sure to indicate who your question is for. This webinar is being recorded, and recordings will be available on the Endocrine Society's YouTube channel and website following the presentation. We are pleased to have with us today Dr. Joshua Joseph of Ohio State University Medical Center and Dr. Leonor Corsino of Duke University. Over the next hour, our speakers will present on the racial and socio-economic barriers to diabetes care and strategies to improve health outcomes in disadvantaged communities. We will end the discussion with a Q&A led by my colleague, Jenny Gingrey. I would now like to invite our first presenter, Dr. Joseph, to speak.
Thank you so much, Ms. Williams, for that introduction, and welcome everyone to this presentation today, Breaking Down the Barriers to Diabetes Care. So my part of the discussion will be the barriers, and that will be followed by Dr. Corsino, most importantly, talking about the solutions, which is what we all need for these barriers. So we will start by defining the disparities in diabetes rates, treatment, and outcomes and underlying root causes, exploring potential insulin-related disparities, and exploring gaps in insulin-related technology utilization across populations. So this presentation is built on the backbone of a lot of work at the Endocrine Society, including this health disparity statement in 2012, led by Dr. Sharita Hill Golden, with many colleagues around the country. This is not a new topic for the Endocrine Society. It is something that has been ongoing, and the advancements made have been tremendous over time, but we still know there is more work to do. So health disparities. The definition is a health disparity is defined as a health difference that adversely affects disadvantaged populations based on one or more health outcomes. Healthy People 2020 describes it as a particular type of health difference that is linked with social, economic, or environmental disadvantage. When we think about health disparity populations, they include racial ethnic minorities, less privileged socioeconomic status, underserved rural residents, and/or sexual gender minorities. This is just some of the topics that are included within that. And so starting with the incidence of diabetes by race ethnicity, many of you know I'm an epidemiologist, so we have to start with some epidemiology. And when we look at this chart here, we see that the incidence, the number of individuals developing diabetes, from 1998 through 2008 in non-Hispanic whites in red, we see that from 2008 forward, it has been declining. We also see for non-Hispanic Asians in gray that from 1998 forward, it has been declining. Unfortunately, for Hispanic and non-Hispanic Black groups, it's been stable to increasing from 1998 forward, so over the last 20 years. When we look at the prevalence of diabetes, the prevalence is greatest in non-Hispanic Black and Hispanic populations. And there have been declines, particularly from 2010 forward in Hispanic populations and from 2014 forward in non-Hispanic Black populations. The numbers have been relatively flat in non-Hispanic Asian and non-Hispanic white populations. And so when we think about the incidence and the numbers increasing for non-Hispanic Black and Hispanic populations, and we think about the prevalence, right? So those flat numbers and even declines, particularly in non-Hispanic Black populations, we know that, if the prevalence is decreasing, it's either due to less incidence or less numbers of individuals developing diabetes or increased death. And unfortunately, what we see in diabetes is that it's the latter, that there's actually increased death among Black Americans compared to non-Hispanic white Americans. In Washington, D.C., where some of you practice, that disparity is 7-fold. In the U.S. overall, it's 2.2-fold. And where I practice here in Columbus, Ohio, it's 1.9-fold. And the question becomes, has that been changing over time? When we look over the last few years from 2009 to 2018, are these disparities in Black-white mortality rate ratios decreasing? And in some places they are. So in Detroit, Michigan, for instance, it's decreased by 2% over that time period. When we look at Columbus, Ohio, where I am, it's decreased by 1% over that time period. But other areas of our country, like here, Portland, Oregon, it's actually increased by 3.5%. When we look overall in the United States, it's decreased by 0.5% from 2009 to 2018. So you can see, based on where you are, the disparities are either increasing or decreasing over time. And that was a lot about our urban areas. What about our rural populations? Well, it's a similar story among our rural populations. This is data from Emma Filoco, a med student here at Ohio State and who's now up in Boston doing her residency. And what she and her authors there at Boston showed was that there's a twofold death disparity in rural areas where it doesn't really matter if you're Black or you're white, there's a large disparity. And then the disparity between Black and white is also large. Here's the Black urban disparity. So you can see much higher rates of death in rural areas for Black populations in the United States, and also higher rates of death for white rural populations in the United States. So where you live matters, whether it's urban or rural. We also want to look at the prevalence of diabetes control from 1999 to 2018. And what you can see when we look at an A1C less than 7%, that the numbers were, improving, went from 44% to almost 57% from 2003 all the way through 2010. But from 2011 through 2018, you can see that those numbers have declined. We can also look at all risk factors for cardiovascular disease and diabetes, including A1C, blood pressure, and non-HDL cholesterol. And you can see only about 1 in 4 individuals meet all those targets. We were making steady progress through 2010, but then those numbers have been declining since then. And in all of these control variables, what we've seen over time is that there's disparities in Black, Hispanic, and lower SES populations meeting these targets. So what are the roots of some of these diabetes disparities? So earlier this year, I wrote a paper with Dr. Golden and Dr. Hill Briggs, casting a health equity lens on endocrinology and diabetes. And in this paper, we looked at historical discrimination and racism during slavery and post, and really went and dug into some of those medical and scientific contributors, including eugenics theory, defining certain races and ethnicities as biologically inferior, closure of medical schools, training Black physicians, and experimentation on vulnerable groups without their consent. This matters because it decreased trust in the medical establishment. Healthcare provider bias towards many minority patients was increased during this time. And there are also the issues of language and communication barriers. Within the healthcare context, this leads to poor access to care, decreased quality of care, decreased participatory decision-making in patient-provider relationships, and decreased health literacy. When we think about the social conditions and policies, we know that redlining and predatory lending led to racial residential segregation and housing insecurity, inadequate investment to maintain public works and school systems in minority neighborhoods, and there's discrimination in access to high-quality jobs with adequate health insurance. These are forms of structural and institutional racism. In the physical context, these lead to decreased neighborhood stability, cleanliness, sidewalks, open space, parks, access to healthy food, and affordable housing. And both of these, the healthcare context and the physical context, increased stress, blood pressure, obesity, cholesterol, and yes, blood glucose, leading to disparate health outcomes in diabetes. So I talked on the last slide about racism, structural racism particularly. And we all know that internalized racism lies within individuals. Interpersonal racism occurs between individuals, and this is kind of what you see on TV, for instance. And then there's institutional racism that occurs within institutions and systems of power. And this refers to the unfair policies and discriminatory practices of particular institutions, think schools, workplaces, etc., that routinely produce racially inequitable outcomes for people of color and advantages for majority individuals. And then we have structural racism, the racial bias among institutions and across society. And this involves the cumulative and compounding effects of an array of societal factors, including history, culture, ideology, and interactions of institutions and policies that systematically privilege white people and disadvantage people of color. And this is taken from Race Forward and produced by David Williams up at Harvard. And so let's give an example of this, and this will be redlining. And so, as many of you know, the Federal Housing Administration operated through the New Deal's National Housing Act of 1934, promoted home ownership by providing federal backing of loans, guaranteeing mortgages, really critical to home ownership. In 1936, there were the residential security maps developed color-coded by the Homeowners Loan Corporation. And the FHA then adopted, and also by the Veteran Administration. And these color codes were designed to indicate where it was safe to insure mortgages for appraisers. Best was green, still desirable was blue, yellow was declining, and red was hazardous. The FHA subsidized builders mass-produced subdivisions, throughout America, but mostly for white Americans, with a requirement that none of the homes be sold to African Americans. And that's still on the deeds, for instance, in many of the communities in Columbus, Ohio, where I live. And areas where African Americans live were colored red to indicate to appraisers that these neighborhoods were too risky to insure mortgages. That's why we call it redlining. And if you want to learn more about it, you can read The Color of Law by Richard Rothstein. There's also a great video, Segregated by Design, that's 17 minutes, as well as an NPR article and story that you can listen to that's about 35 minutes. And so how does redlining, impact vulnerability years later? Well, on the left is the 1936 residential security map of Columbus, Ohio, where I live. And you can see the areas there in red and yellow, green and blue. And then you can look almost 100 years later now, right, in 2020, at our social vulnerability map here in Columbus, Ohio. And you can see that the same areas that are in red on the residential security map from 1936 are also red on our social vulnerability map in 2020, indicating that these areas that, structural inequities in policy influenced over time are still being impacted today. Well, how does this relate to diabetes? Well, I'll give you one map here of our diabetes hospital admissions here at Ohio State University Wexner Medical Center. And here you can see that the hospital admissions are in similar areas that as the red line areas in the map on the left. I could show you the same thing for rates of diabetes, for diabetes control, all very similar, unfortunately, in the central Ohio area, and really goes back all the way to 1936. And so how does redlining, or how do these kind of structural inequities influence health? So we all know about downstream health outcomes, in this instance, type 2 diabetes. They are influenced by midstream determinants: food insecurity, unsafe and overcrowded housing, poor access to high quality healthcare, income inequality, education, etc. And these midstream determinants are influenced by upstream determinants: poverty, racism, and discrimination. And so it's the confluence of all these factors that lead to many of the disparities that we see in type 2 diabetes. If you want to learn more about the social determinants of health and structural racism, I encourage you to read this review by Dr. Hill Briggs, published in Diabetes Care last year. And so let's move on to insulin and discuss the importance of insulin. So this is JL. This was December 15th, 1922. He's 3 years old and weighs 15 pounds. And you can see he's severely underweight. You can see his rib cage there. And there was an important discovery, right? And that's what we're here talking about today, insulin. First injection into Leonard Thompson, unsuccessful on the first attempt, purified, and then rapid improvements for Leonard Thompson. May 16th, 2022, it was made commercially available in England. And in 1923, Eli Lilly and Company began commercial production of insulin here in the United States. So this is our same friend here, Mr. JL. This is February 15th, 1923. So this is 3 months later after receiving insulin therapy. And you can see he looks like a normal little 3-year-old boy at this point, right? Weighs 29 pounds. And that is the miracle and the life-saving nature of insulin, and why it is critical that we don't have inequities within distribution and access to insulin. So when we look at the milestones from insulin being discovered in 1921 all the way through 2010, many milestones here: insulin pens, insulin pumps, recombinant human insulin developed in 1979. Great advancements in the development of insulin. And then over the last 10 years, even more advancements, right? Glargine U300, degludec, pegylated lispro, now biosimilars, Basaglar, Admelog, Semglee, all great advances in insulin over time. Unfortunately, one of the things that we know about diabetes is that it is the leading cost when we think about all conditions to the US healthcare system. And 58% of those costs are in pharmaceuticals, with a majority of them being in insulin. When we look at the cost of insulin over time, you can see that from 2002 forward, it's been rising over the last 13 to 15 years. And that rise has really been unabated, almost triple the cost over time. And so some studies have kind of looked at this. And the first one here is from the Yale Diabetes Center, Dr. Lipska's group. And they looked at individuals with type 1 and 2 diabetes. And they asked, are you using less insulin than prescribed? Are you trying to stretch out your insulin? Are you taking smaller doses of insulin than prescribed, etc.? Because they really want to understand cost-related insulin underuse among patients with diabetes. And what they found was that 26% of participants or patients at Yale were underutilizing insulin due to cost. They also showed that cost-related underuse had a 3 times higher odds of an A1C greater than 9%. So uncontrolled diabetes due to cost-related underuse. A second study examined insulin rationing. And what they looked at was the type 1 diabetes exchange clinic registry among emerging adults. They had 413 individuals, and 37% reported rationing of insulin or diabetes supplies. Some of the things that were associated with that rationing was lack of private health insurance, non-white race, and Hispanic ethnicity, as well as no CGM usage, all with very significant relationships with insulin rationing. In the Look Ahead study, some of my colleagues at Johns Hopkins looked at what are some of the predictors of insulin initiation in patients with type 2 diabetes. And they found, as we would expect, as age increased, insulin initiation decreased. As diabetes complications increased, insulin initiation increased. So both kind of expected findings. What they didn't expect was among Black and Hispanic Latinx populations, there was less insulin initiation in the Look Ahead study. Importantly, these analyses were adjusted for socioeconomic status and A1C over time. And in their work, what they said was that future work is needed to understand the drivers of racial differences in anti-hyperglycemic treatment and to identify patients who benefit most from insulin. So not to make this US-centric, I also wanted to look at data from the UK. So this is from the UK Clinical Practice Research Data Link. And this looked at Black, white, and South Asian groups. And what they found here was that among individuals who were Black and South Asian, the intensification to non-insulin combinations, there was a 1.4 and 1.5 higher odds of treatment inertia among Black and South Asian populations, respectively. When they looked at intensification to insulin therapy, there was a 1.8 and 2.7 higher odds of treatment inertia, respectively. Very important disparities in initiation of insulin based in this instance on race and ethnicity. So let's think back to Banting. And Banting felt that as a physician who had taken the Hippocratic Oath, he could not be party to any patenting of a discovery. It was patented by Collip and Best, but even Collip and Best for $1 transferred all rights and interest to the governors of the University of Toronto. And Banting, Best, Collip, and MacLeod all believe that insulin should be made as widely available as possible without any barriers such as cost, an attitude that seems quaint by today's standards. And so what were they really talking about? They were talking about equity, equity and access and availability of insulin, even all the way back in the early 20s. So lastly, let's take a look at technologies related to insulin. One of them is continuous glucose monitors. And we know that CGMs work very well in type 1 and in type 2 diabetes, improving A1C, less hypoglycemia, more time in target range, and decreasing the frequency of self-monitoring blood glucose. And so, but importantly for these technologies, when we look at CGM here, what we see is that among white and Hispanic groups, and this is data from Shivani Agarwal's group, among white and Hispanic groups, there was no difference in CGM utilization. But among Black groups, and this was young adults with type 1 diabetes, you can see that there was much lower CGM utilization. And when we look at insulin pumps, you can see that compared to white, Hispanic, and Black populations had much lower utilization of insulin pumps. Looking at data on insulin pump use in children, and this is from 2005 to 2019, I'm highlighting the 2011 and 2019 data. What we can see here is that insulin pump utilization here, and this was a study out of the Children's Hospital of Philadelphia, or CHOP. What they showed was that non-Hispanic Black and Hispanic Latinx groups were much less likely to utilize an insulin pump. And there was no difference when adjusted for insurance status. So when we think about these disparities in diabetes, we know that at the core, there are pieces of structural and institutional racism, disinvestment in public works, redlining, policies, practices, and procedures that may be different, that lead to differences, for instance, in hiring and diversity within practice. There are challenges related to the social determinants of health, food insecurity, exposure to toxins, the digital divide, which is critical now more than ever with telehealth, income inequality, education, etc. And these things lead to diabetes disparities, differences in diabetes incidence, prevalence, physical activity, nutrition, obesity, etc. And that there are also management disparities, insulin initiation, insulin access, insulin affordability, continuous glucose monitors, and insulin pumps. And that all of these lead to differences and disparities in diabetes outcomes, including A1C control and, unfortunately, mortality. So in conclusion, there are disparities in diabetes treatment and care, and they are longstanding and founded in structural and racial inequities. Addressing insulin-related disparities by social, economic, and environmental disadvantage around the world is paramount at this time. And we must ensure equity in insulin-related diabetes technology utilization to address disparities in glycemia and diabetes outcomes. And most importantly, the time is now. And so I'm going to pass it on to Colleen Williams to introduce our next presenter. I thank you so much for your time. And in the next talk, we will get into the solutions, which is critical right now.
Thank you so much, Dr. Joseph. So now I'd like to invite Dr. Corsino to speak about some of the strategies to eliminate health disparities.
It's my pleasure to be here today, to be able to follow this wonderful presentation from my colleague, addressing some of the barriers for diabetes care and the impact of insulin uses as we celebrate the 100 years of insulin. And I'm going to try in the next 15 minutes to share with you some of the solutions and strategies to address healthcare disparities. I want to acknowledge that in 15 to 20 minutes, we are not going to solve the whole issue right now. I am just going to share some of my perspective of things we can do as an endocrinologist of healthcare providers caring for patients with diabetes. And it's my hope that my talk serve as a motivation for all of us to be involved and engaged. I agree with my colleague that the time is now for us to be advocates in favor of our patients that are struggling to this day accessing all the wonderful things we have for the management of diabetes. So with that, I want you to frame my conversation with all of you into three main objectives, which I hope I accomplish at the end of our conversation. The first one is to review solutions to ameliorate diabetes healthcare disparities, recognizing some of the barriers that we learned from already in our conversation today. I want to discuss some solutions to decrease insulin access-related disparities, which is a big deal considering that we are celebrating 100 years of insulin, and we still have segment of our population that are not able to access this medication that is life-saving. And the third objective that I hope to accomplish by the end of our conversation is discuss solutions to access to insulin-related technology utilization across populations. So before I start, I want us to reflect on this quote. I think it's a quote that actually resonated with me significantly. And as we talk about solutions and how we can get engaged into addressing things that sometimes might feel daunting for all of us caring for patients in our day by day, I think this is a quote that was included in the AAMC strategic planning to ameliorate racial injustice and about advance health equity. And I'm just going to read it to you. I hope you take a minute to reflect after this conversation what this means to you in particular. But these are the times to grow our souls. Each of us is called up to embrace convictions that despite their power, sans principalities, bend our common define all our humans' relationships. We have the power within us to create the world anew. So keep that in mind. As healthcare providers, we entered this profession with the hope that we are going to be able to help all of our patients, and reflect on what are you doing today? As Dr. Joseph mentioned, the time is now. What am I doing now to ameliorate healthcare disparities when it comes to the treatment and access of patients with diabetes? So we learn also that this is not an easy issue to address. There are many factors that contribute to the existing healthcare disparities that my colleague nicely summarized to all of you. So thinking of solutions also require a complex thinking or framework. So we recognize that we are not going to be able to advance in decreasing health inequities unless we also frame our solutions in a multi-level, multi-layer collaborative approach where not one individual will be responsible solving the issues that we face today. Another important thing to consider when we talk about healthcare disparities, a lot of the research up to recent years and decades have focused a lot on the downstream. How can we actually change individual behavior, behavioral health interventions to help patients be more adherent to recommendations and compliance? But as we learned so far in our conversation today, we have to recognize and acknowledge that a solution to the existing healthcare disparities have to be more upstream. We actually have to identify and target and ameliorate the impact of the root causes of inequities. My colleague nicely alluded to the fact that racism is a big contributing factor to this, and that we need to actually identify strategies to ameliorate racism in this country. We also need to have a more intentionality into addressing institutional power and how institutional power, corporations, business, government, all of them contribute to the existing healthcare disparities that we're discussing today. It's not possible, as I mentioned earlier, to ameliorate healthcare disparities until we tackle also the living conditions where our patients live. We learned already about the housing issues, but we also need to address income inequities. We know that, unfortunately, our racial and ethnic minority population are also the population that actually live in poverty and have income that tends to be significantly lower than our non-Hispanic whites. We also need to actually address diversity that goes beyond race and ethnicity. We know that certain segments of our population receive a lot of violence based on their gender, immigration status, sexual orientation. So it should be an upstream framework to addressing the solutions. Of course, we can never forget about the individual behavioral change that we want to instill in our patients. But I think in order to really move that needle into equity, we really need to work in collaborative efforts into addressing this as a multi-level, multi-layer approach. So advocacy is something that you're going to hear from me in my conversation with you today. Is you need to be engaged. You need to be part of the solution. This is not a problem that just a few of us will be able to change and address. So in here, I'm not going to be reading all of this to all of you, but if you can see here, WHO Healthy People 2020, the County Health Ranking Model, and the Kaiser Family Foundation all recognize that there are many layers to the contributing factors to why we witness some health disparities when it comes to diabetes care. And you can see that, as my colleague mentioned earlier, there are many layers, including community level, institutional level, health system level, providers level, economical and employment level. And all of this, once again, needs to be considered when we're trying to address health disparities, in particular to diabetes care. I want to actually highlight the social factors because it's something that were not discussed earlier. But how do we actually ameliorate also the social cohesion? Incarceration is a big deal, contributing also to inequities in our current system. We also need to encourage people to have more civic participation, which is what I hope to encourage all of you to do today. And also, it's important to address health literacy. Health literacy is a big contributor also to healthcare disparities, in particular when it comes to diabetes care, which is a chronic condition that requires a lot from our patients when it comes to knowing what are the implications of the disease, how diabetes work. If you think about how insulin works, there are a lot of things that we are asking our patients to do, and sometimes we are not doing a lot on our part in order to ameliorate the health literacy impact on addressing diabetes care and informing diabetes care. So let's move on to some of the evidence-based intervention, and I am just listing few of them because of time. We don't have time to talk about all of them, but I want you to think about some effective ways or interventions that have been implemented or are currently being implemented in order to ameliorate some of the existing healthcare disparities. So I have here some examples of the evidence-based intervention that the CDC is putting into place. Some of you here in the call might actually be investigators engaged in the National Diabetes Prevention Program that aim to translate community settings, the evidence-based intervention that actually is proven to prevent diabetes in individuals that are high risk based on pre-diabetes, obesity, and so on. And the goal of this initiative is to actually make this evidence-based intervention accessible to individuals at their community level. We recognize that a lot of the wonderful things that we accomplish in research, a lot of times are not things that are translated into the individuals that will benefit from it the most. So this is kind of an initial step towards helping us achieve that. Also, the CDC has put into place the Appalachian Diabetes Control Translation Intervention and Program, and the goal is to actually, once again, implement some of the evidence-based interventions that we have up to date in order to allow individuals that live in poverty and rural areas to access to some of these evidence-based interventions that have proven to be effective in diabetes control. We also have the Native Diabetes Wellness Program. We recognize that our Native population is also significantly disproportionately impacted by diabetes and diabetes-related complications. And it's a group that we also should pay attention of offering opportunities and interventions and programs that will allow them to ameliorate the impact of diabetes in their population and tribes. And this program aims to work in collaboration with tribe leaderships in order to implement interventions that are culturally appropriate for this segment of our population. We have a lot of data showing that adding the community health workers into the group of providers and teams that help us with diabetes care is effective. There's a lot of research and evidence that's been published up to date that actually demonstrate that this is an approach that has an impact. Also, one thing that was mentioned earlier is health information technology. How can we take advantage of all this technology that we have currently available that is going to help us ameliorate the gap? Dr. Joseph alluded earlier to something that for me is very close to my heart, and it's the digital divide. The digital divide was very obvious during COVID, when we went to lockdown and we have to transfer all of our care to virtual care. That actually also expanded a little bit the disparities in diabetes care, because unfortunately a lot of our minority marginalized populations don't have access to technology, right? So how can we actually ameliorate that gap in order to be able to provide those advantages to every segment of our population? Now I'm going to move on to another quote that I hope it resonates with all of you here, as I try to motivate you to be part of the solution to a very big issue that is affecting us as endocrinologists, as a healthcare providers caring for patients with diabetes. We need to recognize that we will be really misled if we think that we can change society without changing ourselves. And with that, I want to bring up a subject that for some people might be a little bit controversial, a hard pill to swallow, and it's the issue of healthcare providers as a perpetrators of health disparities. How as a healthcare providers and our own bias have an impact on the way we treat patients. This is a subject that has gained a lot of attention also because since 2002, when the unequal treatment statement was released, stating that despite adjusting for multiple factors, minority patients, in particular Black, receive less quality of care from providers. And one of the reasons was bias. So how my own bias have an impact on the way I care for my patients, and how can I ameliorate those bias into having an impact on the way I treat my patients, what type of medications I prescribe, what type of referrals do I make. Then we also want to educate our patients. I think educated patients, activated patients have a bigger role. We have also the possibility of encouraging our patients to also be advocates. I know there are a lot of organizations that have a patient advocacy group that is led by individuals that are impacted by diabetes, that are actually making a lot of significant contribution into addressing the ongoing healthcare disparities. But also we need to educate the public. I think that unfortunately a lot of our public are not aware of the challenges that individuals with diabetes currently have when it comes to affording vital medications like insulin. So educating the public, stakeholders, and policymakers is also critical in order to actually identify solutions to the ongoing barriers and issues that we face with diabetes care. So this is the unequal treatment that I mentioned earlier. And once again, this is just a summary. The clinician bias is one of the several contributors to racial inequities of care. So one more time, I am very big into self-reflection. I encourage you that after this talk, take a few minutes to think about what are the bias that you bring into your patient encounter that might be actually contributing to the barriers and the disparities that we see these days. I'm going to briefly, as I'm reaching the end of my conversation with you today, highlight some of the research that has been published and is ongoing. I encourage you that if you're not familiar with some of the work that is being done when it comes to implicit racial and ethnic bias and it impacts on patient outcomes, that you get familiarized. It's my hope that all of you have heard about this before, my conversation with you today. But if not, I encourage you to read a little bit more. So these are just two examples of recently published papers. One is looking at implicit racial and ethnic bias among healthcare professions and the influence of healthcare outcomes. This is a systematic review that review how the bias have an impact, and diabetes is one of the conditions where this has been identified, but it goes beyond diabetes. It goes to cardiovascular health, it goes to pain management, and so on. And then the second paper here listed, it was a publication by a medical student here at Duke University and my collaborators and friends from the Rich Equity Center, a center that is dedicated into ameliorating health equity inequities. And what they look is the Association of Providers' perspective on race and racial healthcare disparities, with patient perception of care and health outcome. And what they identify is that there is a nice correlation between the two. And one of the solutions or recommendations at the end of this report and study was that providers not only need to become aware of their own bias, but also have to engage into activities into developing skills to ameliorate those bias. This is not new. Once again, we know that there are an array of research that has been published. We have a lot of colleagues, in particular, Johns Hopkins, Dr. Cooper, that has done a tremendous amount of work into help understand how bias have an impact on patient-provider relationship, patients' outcomes, and so on. So these are some of the examples of studies that have seen an association between implicit bias and healthcare providers' behavior. You can see that some of the data have shown that there is less visual contact when a provider has some bias, less nonverbal friendliness. There is some issues with the symptom management of patients. We talked earlier about pain management as an example. There is a difference with treatment recommendations. And there's also evidence that have shown that there is also some disparities when it comes to referral to specialty care when the provider has a higher implicit bias towards Blacks in particular. These are some of the methods or some of the research that is being conducted in order to ameliorate, to finding a solution to the impact of bias into patient care. And these are just two examples. There's also a lot that is being conducted right now, also by some of my colleagues. But education goes beyond practicing providers. A lot of medical school has incorporated into their curriculum some bias training for the medical students. So it goes as early as medical students, residents, faculty, and so on. So educating all of us into how bias have an impact on the care we provide to our Black patients in particular. So how about interventions when it comes to practice? And as I reach the end, I want you to go and read the position statement from the Endocrine Society on addressing insulin access and affordability. In there, you will see some solutions of how we can potentially change practice that will actually improve access to insulin for our patients. But we recognize that in the last couple of decades, with the new development of new insulins, the cost has increased exponentially. But we recognize that there are some type of insulins that are available that are at lower cost. Unfortunately, a lot of us are training our future endocrinologists not in how to use regular and NPH for managing diabetes. And some people argue that maybe we should reconsider incorporating some education on how to use the less expensive versions of insulin to be able to actually ameliorate the gap when it comes to access to insulin for the management of diabetes. Then there are many other opportunities to change the way we incorporate guidelines into the management and practice that might potentially ameliorate some of the discrepancies on what recommendations we're providing to our patients, in particular when it comes to referral to specialty care and so on. So there's a lot of intervention going on. You know, all of you have heard about putting reminders in the electronic medical record, embedding clinical practice guidelines into some of the electronic medical records, sending individuals or providers an email when they are not prescribing certain medication on a patient that qualify based on ongoing and current recommendation of management. So there are many ways we can start thinking about how do we change the way we practice and how we can identify gaps in how we practice that we can actually change in order to ameliorate healthcare disparities in diabetes care. Lastly, I'm going to talk about policy change. I'm not a politician, I have to acknowledge that, but I think that a lot of the conversations we're having today, we're not going to be able to accomplish much until we change policy. And that requires that some of us, even those of us like me that are not a politician and never thought I was going to be advocating at this level, to get engaged and get outside our comfort zone I know a lot of us, I have heard this from many of my colleagues that would say, well, I went to medical school. I don't want to be in politics. Well, I have to break it to you, but if we want to ameliorate healthcare disparities, we also have to advocate for our patients at the policy level with our local leadership, with our national leaders, we are regional leaders. And a good example for this of policy change that we've been able to accomplish with some of my colleagues here in North Carolina, in particular in Durham, is with COVID. Unfortunately, COVID brought to us a lot of disparities that some of us in this call already knew existed because this is the work we've been doing for a lot of time. But it also opens the eyes to a lot of our policymakers, right? And we are taking that as an opportunity to educate them about the existing gaps and how they can actually work together with us into changing things that will actually have a bigger impact into the way we care for our marginalized populations or minority populations in this country. So briefly, solutions to decrease insulin access-related disparities. This is pertaining to my last two objectives of our conversation today. Once again, I encourage you that if you haven't had the chance to read the position statement from Endocrine Society published this year, I encourage you to read it. It's a very easy and quick read. I know we're all busy, but just take a few minutes to read it. And I'm just going to highlight some of the things that are listed in there as a potential solution to decrease these disparities into access to insulin. One is be more transparent with the across supply chain. And you will be surprised that how we don't know the price increase as we move on through this supply chain and how that has a significant impact on the price our patients pay for insulin these days. One of the solutions is to limit future price increase to the rate of inflation. Others is to allow the government to negotiate drug prices. One solution is to eliminate rebates, because at the end, if you read the statement, they would say with rebates, someone has to pay the price. And if you eliminate it and make things more transparent, the hope is that you will be able to actually decrease the cost of insulin. Also, limit the out-of-pocket costs. Expedite the approval of insulin biosimilars. That should also have an impact on the cost our patients pay for insulin. Include real-time benefit information in the electronic health records. So some of us that use electronic medical record, now you have an option where you can actually, even when the patient is sitting in front of you, look and see what will be the out-of-pocket cost for that patient. And then you can adjust your recommendation based on the patient's ability to afford what you're prescribing. And it's important that you take the time to do that. Unfortunately, sometimes we just prescribe what we think is the best, and we don't take the time to actually address the social determinants of health that had a huge impact on diabetes care. And then the last solution is to develop a payment model to lower out-of-pocket costs. And this is really pertaining also to our Medicare population that also has a lot of struggle paying for insulin these days. And lastly, we have all this wonderful technology that sometimes is heartbreaking, where we have patients in our clinic settings that are interested in taking advantage of the technology that we have available, but unfortunately the cost, even with insurance, can be so significant. So how can we advocate into ameliorating the cost, out-of-pocket costs for all this technology, so that way more patients can afford it and take advantage of all this wonderful evidence that has been described earlier by my colleague that show decreasing A1C, decreased rates of hypoglycemia. But unfortunately, not everybody is able to afford these advances. So how can we actually be more intentional into advocating so this can be reached to a larger segment of our population? So with that, my recommendation, and this is a very particular recommendation on my part, my individual recommendation is that in order to ameliorate healthcare disparities when it pertains to diabetes care and access to insulin, we all have to be part of the solution. It requires that we all speak up, that we all reach out to everybody that we can, that we don't stop the conversation. My colleague mentioned that the time is now. I am going to argue that yes, the time is now, but the time was yesterday and 5 years ago and 1 year ago. I think we're past due on the time, and we all need to be part of the solution. So I encourage you to be involved, engaged, vocal, and advocate for our patients that are not able to access all these wonderful advances that we have for diabetes care. So with that, I thank you for listening, and we are going to move on to our questions and answers. So thank you very much.
Thank you so much, Dr. Corsino. I'll turn it over to my colleague Jenny now to go through the Q&A portion.
Great. First, we have a question for Dr. Corsino from Soren Herskovici at UMass Memorial in Framingham. Soren asks, is the bias because of an unequal physical exam or the different medications being prescribed, or is it access to care? Could you expand a little bit on?
So implicit bias has been associated with physical exam, touching your patient. There's research that show that. Prescribing medication, there's a human study that was published in 1999 that showed, in that study, it's a seminal study looking at implicit bias and patient recommendations, show that women that were Black were less likely to be referred for a cardiac cath, even when they were presenting with the same symptomatology. So there is the implicit bias. Implicit bias are unconscious, are rapid mechanism that our brain have in order to make decisions. We know that implicit bias tends to be triggered more when we're busy, when we don't take time. So we go into that part of our brain to make decisions real quick. So part of the solutions of skills that we can learn is to take a step back, a few minutes to breathe before we move on to see the next patient. But there's a lot of research that show that it has an impact, even on the lab work that we order. And if you want, I can share more information about that. We are currently doing a study here at Duke. It's a pilot study actually training healthcare providers into increasing awareness of implicit bias, then educating it about knowledge about how they impact patient care. And then the third leg of that pilot study is sharing strategies to ameliorate the impact of bias in the patient-provider encounter.
Great, thank you. And I have a follow-up question from Dr. Herskovici. Is the issue of gaps in insulin pump access for Black patients, is that because of insurance access or access to specialist physicians, all of the above?
Dr. Joseph, you want to?
Yeah, I can take that one. Thank you so much for that question. And so what we've seen from the data is that, unfortunately, it is not due to any of those factors. So we've adjusted for insurance, for instance, and many of the studies are adjusted for insurance. Others have adjusted for socio-economic status, and they are performed. Most of the studies are actually performed in a single center. So some of the studies I described were performed, for instance, at CHOP, but there have been other studies across the country to show the same thing at other centers. So I'm not singling out CHOP in any way. And so there seems to be a couple of particular factors. One is, how do we think about which patients are appropriate for insulin pumps or for continuous glucose monitors? And this is the opportunity to really have standardized processes and practices. So anyone coming in with type 1 diabetes who meets the criteria for a CGM or for a pump, you offer them a CGM or a pump. You don't say, well, I think this person or that person or this factor or that factor. So, really opening the door to, biases. And so that kind of is to the second point, is what are the practices that we can do to really mitigate implicit biases? And one of them is standardized processes. And so I think that's really critical in this conversation, in this discussion. The second factor is one maybe more on the patient side. And this is health literacy and technology literacy and ensuring that all individuals have equal access to excellent education around these life-saving medications as well as life-saving technologies. And so that's a second opportunity, is ensuring health literacy for your patients. And when patients are lacking in health literacy, really working with the diabetes or a CDCES to really increase that health literacy so that they know the impact of these devices. Because if you don't understand what it's going to do for you, then you may be more inclined to say no to a particular therapy. Thank you so much for that question.
Great, thank you. I have a question from Dr. Olga Timkiv in the Ukraine. She says she's researching the quality of life of children with type 1 diabetes. Could you tell me what methods of psychological correction or any other methods of correction do you use to improve the quality of life of children with diabetes?
I can try to answer. I'm not an peds endocrinologist, so I can just try to answer based on my collaboration with my colleagues here at Duke. We do have a transition of care diabetes clinic that one of my colleagues runs in here. Social support for kids with type 1 is big. Having mental health engaged early on. As we know, when a child is diagnosed with type 1 and they reach adolescence, they require a lot of social support and mental health support during those difficult years of management. So we are trying to build a clinic where it's going to be multidisciplinary, where mental health is a critical part of what we do in order to ameliorate those challenges that patients with type 1 will have. And I hope that answered part of your question, considering that I'm not a peds endocrinologist, but I try to do my best. So thank you for that question.
Yeah, if I could just add to that, Dr. Corsino, I think it's all about trying to make life as normal as possible. And that really goes back to some of our prior conversations about technology, for instance. Someone who has an insulin pump who, can control it from their phone, right? Their friends may not even know they have diabetes, right? And so the social ramifications of that can be huge. But I think it's trying to get them to a place where they can lead as normal a life as possible. And as Dr. Corsino said, really provide that support, which we know is critical. We know between the ages of 16 to 24 in type 1 diabetes is an area that's really challenging. When we think about that transition, and at least here and in some of the national data I've seen, that's when A1C goes up. And so trying to build in those supports is really critical. And you can do that in a number of ways within the healthcare system. And then, I always like to say outside the four walls of the healthcare system. So support in the community, diabetes support groups, et cetera, will be really critical.
Great, thank you. I have a question from Craig Satter. Professional units of CGM can be lent to patients for 7 to 14 days to learn what their glycemic excursions are and how to direct insulin therapy. What do you advise to encourage clinics who are already very challenged with their workloads and maybe technology shy to obtain such units to help their patients?
Well, I can tell you with what we do, and I recognize I work in an institution that might not be representative to where you work, considering that I work in a tertiary hospital, where we do have access to a lot of the technology. But something that is available to providers is being able to link your clinic to a provider account where you can actually look at the patient's information from their CGM if it's linked. And that's something that sometimes when we are down on staff, the provider can actually log in really quick and look at the data without actually having someone to log in and download it if that resource is not available to you. So that's something we try to do when we are challenging on who can do what in our clinic, or we're busy. I will go ahead and do it myself and look it up. And it doesn't take much. If you remember your password and your email, you go there, you look at your patient, you can really quick formulate a result for the last 14 days. And it's very simple. So I don't know, Dr. Joseph, if that's something that you try to do in your clinic as well.
Yes, definitely. And I think the other important point is this is a potential income stream too. If we're talking about dollars and cents and the business of medicine, as that income from those devices and utilizing those devices and reading them, as that comes in, it may be the opportunity to, pay for part of someone's time and put them kind of over that. And so there, you kind of have to think about all the costs as well as the profits that may come from that as well.
One thing I didn't mention is that there are systems that you can acquire. Of course, they're not cheap. You have to pay for it. But we have system in our clinic that we allowed you with one technology be able to download meters and sensors from different brands. So that's also something people can consider if that's accessible to them financially.
Great, thank you. That's all the questions we have in the queue.
Awesome. Thank you so much, Jenny. So if you have additional questions, feel free to contact the Endocrine Society Media Relations team. We're all available at media@endocrine.org. And we want to thank our speakers, our attendees, and our supporter, Lily, once again, who made today's discussion possible. And as a reminder, the webinar will be available on our 100 Years of Insulin website and YouTube channel following the webinar. And more details on upcoming events around 100 Years of Insulin are available on our website as well. And thank you all so much for joining us today.